Good afternoon, good evening, good morning if it happens to be morning where you're joining us. Welcome to the 2021 Arrow Lecture on Ethics and Leadership. My name is Sara H. I am a professor of political science and the faculty director of the McCoy Family Center for Ethics and Society, which is the sponsor of the Arrow Lecture Series. The Arrow Lectures were created in 2005, and they have become among the most prestigious lectures here at Stanford University. Previous Arrow Lectures include a roster of exceptionally distinguished scientists, social scientists, philosophers, and political leaders, including people like Jennifer Doudna, the recent Nobel Prize-winning biochemist, Stanford alumnus and former mayor of Stockton, California, Michael Tubbs, and two other Nobel Prize winners in economics, Amartya Sen and Esther Duflo. Speaking of these Nobel Prize winners, the Arrow Lectures are named in honor of Stanford Emeritus Professor Kenneth Arrow. Ken, a colleague of ours here for many years at the Center for Ethics and Society, was one of the most renowned scholars ever to have taught at Stanford University and one of the most influential economists of the 20th century. He died in 2017 at the age of 95 years old. He is the second youngest recipient ever of the Nobel Prize in Economics, winning it at the age of 51. But perhaps even more remarkable than that fact is this: 5 of Professor Arrow's students have gone on to win the Nobel Prize in Economics. We honor Kenneth Arrow today with a presentation by Dr. Sara Cody. She is our guest of honor this evening for the Arrow Lecture. And the format for this evening is that Dr. Cody will talk for roughly 30 minutes. She'll be joined then on the Zoom stage by Professor Michelle Mello in dialogue for 20 minutes or so. And then there will be open Q&A so that you too can participate in this conversation. Let me now offer an introduction of Dr. Sara Cody, our lecturer for this year. Dr. Sara Cody was born and raised here in Santa Clara County, and she received her bachelor's degree from Stanford University and then completed a medical residency in internal medicine at Stanford Hospital. She is a local. She joined the County of Santa Clara Public Health Department over 20 years ago and currently serves as both health officer and director of the Public Health Department. And in those dual roles, she oversees more than 30 programs dedicated to providing services that prevent disease and promote health and equity for nearly 2 million people in Santa Clara County. Of course, like her fellow public health officers, she was at the forefront of the COVID-19 response, and with several Bay Area health officer colleagues, she ordered the first shelter in place in the entire country in early March 2020. Now, that decision was bold and controversial. In ordinary times, county public health officers are part of our basic health infrastructure, but they carry out their work in relative public anonymity. Almost no one knows the name of their county public health officer, or at least no one before the coronavirus pandemic did. But the shelter-in-place decisions changed all that, thrusting public health officers into the limelight. And those shelter-in-place orders raise powerful political as well as health questions. Where exactly did county public health officers get the authority, in some cases the sole authority, to issue shelter-in-place edicts? How do democratic societies balance the powerful decision-making powers of county health officers against potential other rival values? Those will be the subject of some of the conversation tonight. And as a signal of just how controversial Dr. Cody's decisions were, it's worth mentioning here that she has been protected by local public sheriffs from threats to her own well-being as a result of her controversial decisions. Dr. Cody will be in conversation with Michelle Mello, a professor of law, as well as a professor of medicine and an affiliated faculty member at the Center for Ethics and Society. She has written widely on ethical, social, and medical dimensions of the COVID-19 pandemic and the response to it, and she is a leading health law scholar in the country. With that, I please welcome to the Zoom stage, Dr. Sara Cody.
Thank you, Rob. It is a real pleasure to be here. I want to as well thank the McCoy Family Center for Ethics and Society and Joni Berry in particular for coordinating everything to make this happen today. To say that I am humbled to be invited to give this lecture is an understatement of vast proportions. I was so humbled, in fact, that I had many second thoughts about accepting the invitation to speak. I have heard so many stories about Ken Arrow from many friends in the Stanford community. And I know that his intellectual range and interests were vast and legendary, and he is really unparalleled. So it is a deep honor to be here today speaking in a lecture in his name, and thank you so much. So in the next 30 minutes, I want to share with you a bit about the run-up to the March 16, 2020 shelter in place, and really the biggest decision that I've made in my public health career, which was to issue that order to the whole community to shelter in place. I want to talk a little bit about the limitations of a local response to a global pandemic. And I want to give everyone a sense for how I navigated the authority that's given to local health officers in California. And finally, I'll close with talking a little bit about the aftermath of that decision. So to start the story, the lead up to March 16, I want to just share with you a little bit of the run up about where we were in late January and early February of 2020. It was January 23rd when we formally activated our department's Emergency Operations Center, and we did that because the tempo of calls from concerned physicians was growing rapidly every day, and we really couldn't manage it without getting everyone together to gather information and share information with concerned physicians. And I would have to say that even then in late January, I had a hunch that our county would be one of the first counties to see cases in the United States, simply because this is a pattern that we had seen before for infections circulating in Asia. Santa Clara County is one of the most demographically diverse populations in the United States. People living in our county are from literally every corner of the globe. 40% of people living in our county were born outside of the United States. And our travel patterns, for personal and professional reasons, there's lots and lots and lots of travel to Asia and to China in particular. In 2003, for example, Santa Clara County had 2 of the 8 confirmed cases of SARS in the entire United States. So just to say that in some ways, we were expecting to see COVID arrive early here. So indeed, by February 2nd, we'd already had 2 cases. Both were travel associated, returners from people returning from Wuhan, China. And that is in particular because we were only allowed to test people who were returned travelers from Wuhan, China. And so that is all that we were finding. But we began to increasingly just have a terrible feeling that something was happening that we were not able to see. On February 4th, one of my health officer colleagues and I sketched out a table on a large Post-it that we put on the wall of the Emergency Operations Center, and we entitled it, "Are We Different?" And there on that day, on February 4th, we knew from the CDC website that the United States had recorded 260 persons under investigation. These are people suspected of having SARS-CoV-2. And our county had recorded 14 or 5% of those in the US. The United States had recorded 11 laboratory confirmed cases, and we had recorded 2. So in other words, nationally, 6% of the persons under investigation had confirmed to be cases, but locally, 20% of ours had confirmed. Or another way that we looked at it was we thought, well, We have at the moment 11% of the cases in the country, but our population is only 0.6%. So these are tiny, tiny numbers, but it gave us an early inkling that we may be in for some trouble. The next day we updated our chart and the trouble continued. It's important to note that on the following day, on February 6th, San Jose resident, Patricia Dowd, died suddenly when the left ventricle of her heart ruptured. We did not know at that time that she had died and that she had died of COVID. We were not able to discover that until the middle of April when coroner's results came back from the CDC. But it's important to note because the unease that we felt was justified. There was more virus circulating than we knew. The day after Patricia Dowd's death on February 7th, finally, the very first lab testing kit under emergency use authorization from the Centers for Disease Control arrived in our lab, and our lab director stayed up all night to validate the test so that we would be ready to go the next morning. But when he ran the first set of samples, he noticed something was amiss. One of the controls wasn't working properly, and so he stopped. And you probably all know the story there. This was a problem with one of the controls sent out by the CDC lab. So we were told to stop, and we did. Unfortunately, the next few weeks was a period of complete blindness. It was excruciating. It was eerie. It was extremely uncomfortable. My colleague in New York City described the feeling as being kind of like being in a horror movie right before the alien pops out. So finally, later that month, February 26th, we were finally given the go-ahead to use that lab test. And it was the first or second sample that we tested that turned up positive. And this was our first confirmed case of community transmission. And a woman in her 60s who hadn't traveled anywhere. She, lived in an apartment in a community in the county, became very ill, ended up in the intensive care unit. And she was our first confirmed case of community transmission, which we announced on Friday, February 28th. So there we were finally with the capacity to test and to look. But our capacity was still quite limited. We could just test between 12 and 24 samples a day over the next few weeks. But the more we looked, the more we found, and we began to see a very worrisome pattern. We didn't yet have a sense, we had no formal studies to say, well, how bad is it? What's the real prevalence here? And so we decided to allocate a small portion of this very limited set of test kits to do a little study. We had 4 urgent care clinics, and if patients came in with flu-like symptoms and tested negative, we tested them for SARS-CoV-2. Those turned out to be very important results, and I got those results the weekend of March 14th and 15th. And they showed that 11% of the specimens from patients that were flu negative were SARS-CoV positive. So again, not a random sample by any means, but a very, very important little piece of information. I also want to this is a little bit personal, but during that time, I'd been having a number of conversations with my husband, and I am extraordinarily lucky to be married to a Stanford faculty member who spends a lot of time thinking about pandemics and infectious modeling. And he had reminded me of some basic properties of exponential growth, and essentially that if I were going to do anything bold, I better do it fast because it would have tremendous economic and social harms. And but if done late, I would miss the extraordinary benefit of acting early. So that also stayed in my mind. So looking back, it may have been even before March 16th that we had enough evidence to take early action. But there were 2 things that were holding me back as I think back of it. One is I didn't have that surveillance data from the clinics, and that turned out to be quite important. And the other is, to be perfectly honest, I don't think that I was emotionally ready to make that decision. Things were just moving too fast. On Friday, March 15th, I had a press conference to announce that I was prohibiting gatherings of more than 100 people. And during the press conference, I actually choked up because as I was saying it really hit me the full force of what it would mean for 100 people not to be able to gather and how many activities wouldn't be able to occur. So that was just on Friday. And on that Friday, we had 66 cases and 1 death. Fast forward 48 hours later, and our cases had almost doubled to 123, and we had 2 deaths. So these numbers aren't large compared to what we experienced during the pandemic, but the rate of growth was breathtaking. So on the morning of Sunday, March 15th, my dear colleague in San Francisco, Dr. Tomas Aragon, called, and initially the conversation was, couldn't we all get on the same page as far as the number of people that we would allow to gather? And as Tomas and I talked, it quickly became apparent that we were having the wrong conversation, and that rather than speaking about the limits on large gatherings, what we really needed to be discussing was shelter in place. And we were looking at a table of cases in Italy, in northern Italy, and comparing it to a table of the growth of cases in Santa Clara County. And it was apparent that we were almost exactly 2 weeks behind Italy. So that was quite a day. By noon, we had convened our fellow health officers from around the Bay Area to discuss a region-wide shelter in place. We'd invited our county council to the call so they could listen in with us as our partners and help us craft legal orders that would be clear and legal. And by the evening, we were on a call with county executives, county councils, and health officers from around the Bay Area to all get on the same page. By noon the next day, we had a press conference, and the order was effective at midnight that night. So just reflecting back on what was it that allowed us to act so quickly and act together. I think that 2 things. One is trust. The health officers in the Bay Area, we know each other well, we trust each other, we respect each other, and there's a tradition of working together that goes back to the 1980s when health officers worked together to address HIV as it was emerging in our communities. Normally, we meet every other month for dinner and talk about whatever the public health issues are of the time. So those relationships helped us go quickly. The second is the Health and Safety Code in California, which gives enormous authority to health officers. In fact, it gives us duties to act. A particular section in the Health and Safety Code is the one that I think is central to the shelter-in-place order and many that followed. And it says that each health officer, knowing or having reason to believe that any case of the disease is made reportable by regulation of the department, or any other contagious, infectious, or communicable disease exists or has recently existed within the territory under his or her jurisdiction, shall take as may be necessary, shall take measures as may be necessary to prevent the spread of the disease or occurrence of additional cases. So the key here is that it says shall, not may, not if you feel like it, but if you know the disease is spreading, you must take action to prevent it if there's harm. So I want to say that as Rob Reich mentioned, before the pandemic, no one had really ever heard of didn't know who their local health officer was and didn't even know that local health officers existed. And I think that's because generally the way that we work, we are a very behind the scenes bunch. And many of us tend to be kind of introverted personalities who like to work behind the scenes and aren't accustomed to being out front. So this was a distinct departure. And second, this really unilateral decision making is really a breathtaking departure from normal public health practice, because normal public health practice is all about stakeholder engagement and shared decision making. We take a lot of time to make decisions, and usually our time horizons are very long. So this was quite different. Second, as I reflect on this shelter-in-place decision, I think we were really living the limits of this federated system that we have in the United States. And this would become more stark as the pandemic wore on. I think that the lack of coordination and leadership at the federal level effectively pushed many of the decisions, particularly those that were politically unpopular, to the states, and then from the states to the county. So the local level is really where things were happening. I have to say that carrying this amount of power and authority during an emergency was exquisitely uncomfortable. But at the end of the day, it felt that it was a duty that I had, and that my choices were either to carry out my duty or to step aside, that this is what the role required, for better or for worse, popular or not popular. That was the duty that I had by accepting this role. When I think about how else things might have worked, I think that in a state of emergency, of course, things have to work differently than they do in a non-emergency. And I think it would have been very difficult, if not impossible, for a local elected official, one, to act as quickly as we did, and two, to act as boldly as we did. Because it's the decisions that we were making were not popular decisions. Second, I think it's important to remember that the Health and Safety Code and the language in the Health and Safety Code that gives this power and authority to health officers was put in place by lawmakers who, at one point anyway, thought that this was a good idea. I also just want to say that I think that in the context of the pandemic, how much governmental structures matter. So my colleagues who serve in other large metro areas throughout the United States are in different governmental structures, and many of them report directly to a mayor. And I know my colleague in New York City, Dr. Oxiris Barbeau, wanted to issue a similar shelter in place, but couldn't because she needed the mayor to go along, and the mayor wasn't ready to do that. I also want to say that in Santa Clara County, I could not have been more supported by our local government. Absolutely could not have been more supported, and it really mattered. I report directly to the county executive. He is hired by the Board of Supervisors to carry out the business of the county, and he became incredibly important. He really just kind of acted as a human heat shield for me, and helped and protected me so that I could make public health decisions, and he would handle the rest. So, not surprisingly, public health authority is being challenged across the country. No significant threats that I know of in California, at least not yet. But at least 15 state legislatures across the country have passed or are considering laws to seriously limit the legal authority of public health agencies and officers. Just a few examples of what that looks like. In Montana, There's a new law that prohibits local boards of health from issuing quarantine orders. So that means that they cannot separate someone who is exposed to an infectious disease and may be infectious. They cannot separate that person to prevent the spread of disease. So this is a cornerstone of communicable disease prevention and control that's now been removed. In Texas, a proposed bill would preempt local emergency action to the extent that it's inconsistent with the orders of the governor or the state health department. And in Ohio, a new law took effect just yesterday. And this law allows the legislature alone to rescind any order or action by the state health department or director of health to control the spread of a contagious disease. It's worth noting that the governor had vetoed this law, but that veto was overridden by the legislature in Ohio. So I think these developments are deeply concerning because they move the decisions from public health professionals to politicians. It's clear that public health professionals have a singular focus and a duty and commitment to protect the public health. That's why we're in the field. I think it's immensely more complicated for elected officials. So I want to just talk a little bit about the history of health officers and health officer authority in California. First, just for background and context, every county in California has a local health officer. In addition, 3 cities have their own health officer. So there's 58 counties and 3 cities with a local health officer in the county. And the health officers are given various responsibilities, duties, and authorities all over the law in the Health and Safety Code and in other codes as well. And some of them are outdated and sort of difficult to fathom. For example, one from 1949 that's still on the book says that health officers are responsible for sewer system connections and may build the connections themselves if the homeowner fails to comply. And another one is around the responsibility for safe disposal of greasy kitchen rags. So clearly some cleanup needs to be done. However, the health and safety code that I mentioned that was central to the shelter in place order is relatively recent. It's from 1995. I don't know the history of how that was put on the books and what prompted it, but it's relatively recent. So the aftermath of lifting the shelter in place, I would say the reopening turned out to be far more complex than issuing the original shelter in place because of considerations about both when to lift the restrictions and to know when it was safe enough and how and where to lift the restrictions. The original order defined essential businesses and activities. And as soon as that was done, there was intense lobbying. And the lobbying really focused anywhere there was a discrepancy between the state's order and the local order. So for example, our local order didn't allow gun shops, marijuana dispensaries, or actually we didn't allow construction either. We were quite strict. And so we immediately began getting lots of lobbies from gun shops and marijuana dispensaries and construction. Why gun shops and marijuana dispensaries were initially protected is an interesting question. Second, it was also challenging because we still didn't have the tools in place to really implement a serious containment strategy, because for that we would need a really widespread testing as well as scaled case and contact investigation. And those were not scaled and in place really until midsummer for a variety of reasons. So it was extraordinarily difficult to hold the line and protect the public when we didn't have the tools coming online to address the health of the population in a different way. There are two two analogies, two visuals kept coming to mind as this was happening. One is it felt like we were running an ultra marathon with no water, no food, and no map. But we knew that we had to run, because if we didn't run and get to the end of the race, people would be hospitalized and people would die. So we just had to forge on with what we had. When we were making, I would say another guiding principle in these decisions was one of equity. It was apparent from early on that our highest case rates were in communities that are traditionally disproportionately affected by any health condition that you might imagine, with lots of structural impediments to be able to absorb something as serious as COVID. Incomes with, communities with lower incomes, crowded housing, multi-generational housing, and many household members working outside the home with many opportunities to bring COVID back in. And I honestly didn't know how to ensure protection of these communities without keeping the overall community transmission rates and prevalence as low as possible. I think that in general, the community was in support of the actions that we as a county were taking, and that by and large the Bay Area was taking as well. Not everyone, but in general, what we heard from the community was one of support and relief that we were providing protection. The backlash really came from, I think, initially from a number of groups that were anti-government to begin with. I initially started receiving threatening letters that progressed and were ultimately traced to someone who was affiliated with the Boogaloo Boys, which is a far-right extremist group. Also had a lot of threats and protests, as did many of my fellow health officers, from another group called the Freedom Angels that were traditionally an anti-vaxxer group, but refashioned themselves to be anti-mask and anti-contact tracing. And then a number of us have received some threats and such from another group, the Sovereign Citizens, who basically don't recognize government authority at all. So through this, my focus and those of other health officers I know who were receiving similar threats was really just to keep our head down and keep doing our work. And I was very fortunate to have protection, not just from the county sheriff, but also from my county executive and my county council, who have been phenomenally supportive throughout. Needless to say, there were significant challenges to fighting a global pandemic locally, and I think this goes back to the decisions really kind of fell from the federal to the state and got plunked on the heads of the local health officials. So one is it was an enormous amount of pressure. The other is it was not particularly effective, I think, to have this patchwork of policies that in many cases went county to county to county. It was extremely challenging to continue to ask the residents of Santa Clara County to abide by some fairly strict regulations when in other parts of the state, and sometimes even in neighboring counties, things were opening up a bit more. So it felt like we were asking a lot of work and sacrifice on the part of residents here for benefit that might be felt elsewhere. I think that a fair criticism of our response to the pandemic would be that we were ignoring our public health roots, and why weren't we looking at health in a more holistic way? This is something that I've thought about a lot, and it's bothered me tremendously. We wanted to chart the most health protective path forward, And in many cases, we simply didn't have the data or information to understand really with feedback that was quickly enough what the what the harms and benefits of various decisions were. So I hope that in the future, there will be a flood of work on this and analyses to help us make these decisions in the future. I guess just a couple other things before I close, and that is that if I had the sense that if we had relaxed more and lifted restrictions, I know that there would have been so many more health harms in terms of COVID with hospitalizations and death that in turn would have translated to significant, not just harm to the families and individuals that had lost a loved one, but community harm and community fear from having this. And I think that even with the relatively low levels that we maintained in the county, a lot of the behavior of people that people exhibited had to do with fear of COVID as much as with the orders that were in place. So a few lessons learned before I close, and I'm really looking forward to engaging in conversation with Michelle, is one, the importance of trust. We couldn't have made the decisions that we did if we hadn't spent years building trust with each other. I also think that there was enough trust in us as government that enabled people to understand why we were doing what we were doing and to comply. Second is the effectiveness of our response was limited. And I think the lack of alignment with federal and state policies was deadly. We were making decisions on behalf of health, but other arms of government that would have been helpful to ensure that small businesses could be made whole or people could have their paychecks restored was not under our control, and that was enormously difficult. And finally, I think that public health emergencies, just by their nature, are not terrifically democratic. So I look to the political scientists to help answer the question of if not public health officials, then who should be making these decisions and how. In closing, I again want to thank Rob Reich and Joni Berry and the Center for Ethics and Society for inviting me to give this lecture today. And I would also very much like to publicly thank my colleagues at the county for their incredible support, and many colleagues at Stanford, many colleagues at Stanford who have partnered with the county on all kinds of analyses. You've been phenomenal thought partners, and we are very, very, very fortunate in the county to have the university in our county. So I look forward to more conversation with Michelle and questions from all of you. Thank you so much.
Dr. Cody, thank you so much. That was terrific and a fascinating little glimpse into what has probably, I would imagine, been the most difficult year of your professional life. I want to just begin by thanking you for everything that you've poured into keeping us safe over the past year. And I know I speak for many of our attendees, many of whom have already contributed comments in the chat to that effect. But you know, I remember back in February of 2020, I was having a conversation with Doug Owens, your husband, and my boss at the medical school. And he said to me, "Sarah's working like a dog." And I said to him, to my mortification now, "On what? There's 63 cases in Santa Clara County." And Doug, in his patient way, gave me to understand some of the indicators that you talked about that were really filling you with dread. And I realized that, like the rest of us, I was at that time sleeping the peaceful sleep of passengers on a ship who don't know they're sailing into an iceberg. But you took the helm very early, and you have stayed there. And we recognized how exhausting that was, and really, you know, whether we've agreed with every decision you've made or not, really thank you and owe you a debt of gratitude for that perseverance. I want to offer just, I think, 2 or 3 reflections on some of the themes in Dr. Cody's talk, and then I'll open a conversation with her. One of the things that she talked about that I think is worth dwelling a little bit on is the concept of duties to act in the face of an emergency. I teach and write about public health law, and 95% of the legal cases and the scholarly writing about public health powers is all about what government can do when individuals assert their individual rights and liberties as counterweights to the exercise of the powers that government has. But Dr. Cody's quite right that health officials also have duties to act. The law requires them to do so. And of course, they also have moral duties to protect by dint of the role that they've assumed. She talked about the sections of the California Health and Safety Code that impose this duty. And I was reminded that there was a lot of discussion of this after SARS, when the anemic government response, particularly in Canada, led to public outcry that not enough had been done. Well, here we are in a very different posture now, and it really brings to mind the fact that health officials can really be whipsawed in terms of the public demands to do something, but not too much, get in early, but not too early. Calibrating this can be really difficult. It really is an art form, but I think Dr. Cody's quite right that there is a duty to act, and it's a duty that we saw go unfulfilled in so many places around the country, including Washington, D.C., in my opinion. The second theme that I heard in the talk was about governance during pandemics, during emergencies more broadly. The balance of power, separation of powers, who should have how much power and for how long. And I think some important context there is that prior to 9/11, state laws around the country did not give much emergency power to health officials at all, nor even to governors. And people started to realize at that time that if terrorists were to attack with a biological or a chemical weapon, we would not have the tools legally to mount an effective response. And so this led to a massive legal modernization effort. And the sort of social deal that we struck was that health officials would be vested with fairly sweeping emergency powers. And in exchange, we would require the exercise of those powers to be time limited. And we were going to vest individuals additionally with some procedural due process rights in the event that they were confined for health reasons. Now, during COVID, it seems to me that social compact that we struck after 9/11 has really been under pressure and indeed has broken down, maybe in part because the orders that were imposed were just of such unprecedented scope and duration. But here we are again, asking the same questions that we asked 20 years ago. How much power do health officials and governors need to be able to mount an effective, flexible, but constitutionally bounded public health response to emergencies? And I think that's a conversation that we will continue to have. Finally, let me just comment a bit on the trust issue that you raised, the importance of public trust. There's a lot of research and scholarship that links trust in public officials to people's sense of legitimacy, meaning their belief that officials have the legal and moral authority to do what they're doing. And there's research that in turn links that sense of legitimacy to compliance, people's willingness to go along with what it is officials are doing. Trust in public health officials, even though their work is pretty invisible, as Rob said, has historically been really high. For example, in a survey that I did in 2011, 85% of American adults said they trusted the CDC and 74% trusted local health officials like Dr. Cody. But things have changed during COVID. And absent that trust and legitimacy, as you talked about, it's very hard to get people to do burdensome things voluntarily. And that leaves coercion, that leaves orders if people won't do things voluntarily. But if trust is lacking and you issue orders, you have the possibility of the kind of backlash that you talked about. I think it kind of remains to be seen whether the current polarized feelings about health officials endure very much beyond COVID. But if they do, it worries me that it could be harder for health officials to accomplish a bunch of other things that they want to do if this sense of trust and legitimacy has been undermined by our national experience over the last year, whether it's from health officials doing something that people perceive as overreach or health officials not fulfilling their duty to act. So again, a very difficult tightrope to walk. So with those short reflections, let me turn now to a conversation with Dr. Cody. I have a few things I've been wondering about, and then I will open up to some of the questions that we've gotten. Maybe to start us off, Dr. Cody, I wonder if you could, again, take us back to last spring. As you started to realize how serious COVID was going to be, what ethical commitments did you make to yourself? Meaning, what values did you commit to promoting in your work, and what kind of example did you think it was important to set as a leader?
I was thinking, really focusing on my job as a health officer, and that the decisions that I needed to make needed to that it was my job and my duty to protect the public health, and the challenge, and to do my best, and that if I thought that I wasn't doing my best, or if anyone thought that I wasn't doing the right job, then I should leave. So I think that in these jobs, you need to be very ready to leave. You need to do your work, be ready to be fired, and that's actually quite important. You can't hang on. You can't hang on to the position too much. You need to just do. I felt that I needed to do which was most health protective. It's sort of like the whole county is my patient, and I have a duty to take the best care of my patient as I am capable of doing. And I also I think something else that I thought a lot about was, what is it that I'm not seeing? What is it that I don't know? What information don't I have? What perspective do I need that I'm not incorporating? And I thought about that a lot, and it worried me a lot, because it's an enormous amount of power to put into one person, and I can't see everything, and I don't have all those perspectives. So I thought about that quite a bit.
And to this issue of thinking broadly about the harms of decisions, you mentioned this sort of tension between focusing on COVID and other aspects of health harms. And of course, there are many people who think that you didn't focus enough on non-health harms. I wonder what your thoughts are about the extent to which health officers should be weighing non-health considerations, non-health values when making big decisions like shutting down businesses and schools. As you and I have talked about a little bit, in some states like New York, they're actually legally prohibited from doing that on the basis that's too far out of their lane. They don't have any expertise to do that, and that's the job of a legislature. And it sounds like you perceive some constraints in California law as well. So in an ideal world, what kinds of interest weighing should health officers engage in?
So it is true that in California, there's language in so many places in the health and safety code, and the vast majority of it is focused around communicable diseases, or environmental health harms, pesticides or toxics or restaurants or something like that. But that's sort of in the law and the health and safety code. But in public health practice, the way we practice public health is we think about health very holistically. So if you're going to think about the social determinants of health, as we do in public health, you think very broadly. And so my challenge and the tension that I have felt over the last year and a half has been, one, feeling constrained, like as far as an order, I should really just think about communicable disease. And I also know that all of these economic social harms translate to health harms. And it's like, I wish that I could take the economic and social harms and magically convert them to some health harm scale, right? And then compare trade-offs. But that little formula, it doesn't exist, best I know. And you can't sort of like, when you're moving so quickly, I mean, we had to make decisions really, really, really fast in the face of enormous uncertainty. And there's not time to go back and do those analyses. But that's the kind of analysis that I would really like to happen now. And if there could be some system, I have no idea what it might be, so that we can incorporate a more holistic sense of health in making the decisions. That would be enormously helpful. And I think that it would help the public see why the decisions are being made the way that they're being made.
on that note, there are a lot of people who think that the way we repose power in health officers is just fundamentally undemocratic. And, we've heard those complaints over and over. Are there ways in which you feel yourself to be held accountable to the public, notwithstanding the fact that the law gives you so much discretion?
I think the way that health officers are accountable is that ultimately report to elected board of supervisors who can fire us. So that's sort of where it is at the end of the day. If you're the people elect the county board of supervisors, the board of supervisors supervises the county executive, who supervises the health officer. And in other counties, the board just directly supervises the health officer. And so that's the ultimate accountability, is if they don't like what you're doing, they can send you on your way.
So let me ask one more question, then I'm going to open it up. We lost very dear colleague Deborah Rohde this winter, who's written a lot about moral leadership, including a terrific book called Moral Leadership. And in that book, she writes about the importance of what she and others call a feeling of nearness, which is a leader's moral awareness, their recognition that a situation is imbued with ethical issues. And feeling nearness is about having empathy for and solidarity with people who are losing out because of a leader's action. As I think about the last year and the social isolation that we've all been living under, and just the fact that public health is supposed to be about just being guided by science, and in public health we measure our impact with numbers. How did you cultivate a sort of feeling of nearness with the people that would be burdened by your decisions? Was that difficult to do?
Yes and no. I mean, one is, it is helpful to be a public health official and to practice public health in the community where you grew up and that you belong to, because I have separate than a duty that I have from the health and safety code. I also feel that as a community member, I have like the duty to do right by the community where I've always lived, and with people who I love, and I have lots of attachments. So I think actually I didn't realize this until I was speaking with someone about it recently. Most of the Bay Area health officers grew up in the county that they serve. So and I don't know if this is common, but most of the Bay Area health officers have deep connections and roots to the community that they serve. Certainly true in San Francisco, true in Marin. And I think that's just really important to note. So we're taking actions that impact the community, but we're also members of the community at the same time. I had a number of really key conversations with a number of community members and leaders that I've known throughout my practice in public health, and I would turn to them and have sort of separate private conversations to gut check things with them, and I actually found that quite helpful. And so, for example, when I was like really in enormous anguish about whether I was doing the right thing and whether this, the very communities that I'm trying to protect, the communities in East San Jose and in South County and the African ancestry community, what were the actions that we were taking, ultimately helpful or well received. And so these are just, individual conversations with people, but those individual conversations with people, those leaders told me, absolutely, don't you dare let up. You stick to your guns. And one old friend and colleague of mine, she said very frankly, if people in my family die or in my community die, that's it. But if they lose their business, we can make that right. We can figure out a way to put that back, but we can't put that back when someone dies. So that's not a it's not a community-wide population-based survey, but I did use those conversations just to help me kind of check my perspective and make sure that I wasn't veering, too far off track.
So let me turn now to one of the questions from the audience. One person asks, what are some lessons learned from this pandemic that our county will implement going forward, particularly as it impacts minority and low-income groups?
I think this is really the central question. And when I think about what does public, what's the infrastructure that public health needs to build to do better next time? And of course, there's, the data and technology infrastructure is so fragile. And of course, that all needs to be built. But I also think that the work that we are starting to do to advance racial and health equity by developing partnerships with community leaders and moving from community engagement to community to real power sharing. I think that's actually the work that we need to do that's going to set us up to be more effective in for the next pandemic. That work takes enormous amounts of time, and it's about relationship building and trust building and power sharing and working together. And we have a little bit of experience and now growing experience in the public health department. And I actually think that is probably where we need to put a lot of our efforts going forward.
And have you been able to give any thought to the global pandemic as the burden of disease now shifts increasingly overseas? Are there any lessons that you take away about what we need to do in our global system for, in terms of scaling up the types of responses that we had to implement here?
Yeah, I just would observe that as we, rolled out vaccination in Santa Clara County, and we got, our vaccination rates are fairly high, and we now have lots of excess vaccine, as is true across the state and in many parts of the country. It is extremely uncomfortable to have vaccine not being used when, our neighbors in Mexico don't have enough vaccine. Central America, you name it, there's not enough vaccine. I don't know what the role of a local government would be in that, but Santa Clara County is a very global community. As I mentioned in the beginning of my comments, people who live in Santa Clara County really come from every corner of the globe and have connections to every corner of the globe. We see infectious disease patterns actually reflect global migration patterns. So we are very, very, very connected, and it's in our interests to ensure that there is, pandemic control. So, in even a very self-interested way, it is in our interest to see that the pandemic is controlled. What the levers are in a local government, in a local county, I'm not sure. Curious if you have any ideas.
I'm much more interested in hearing your ideas in the short time that we have remaining, but let me move on. And maybe if you don't mind us getting a little bit personal for a second, you talked about some of the threats against yourself and your family, and some of our attendees are wondering a little bit about how you manage yourself in the face of those threats. You talked about the sheriff, but did you think about quitting? Over 250 health officers around the country have quit or have been forced out during COVID. What kind of pressures were you getting to act differently or get out? And how did you deal with that?
So I feel like I might be the most supported health officer in the entire United States. I mean, I have phenomenal support in the county from county leadership, from the county executive to the county council to the county sheriff, and every which way, and that has really kept me here. One is I've always loved working for the county, but we were sort of like forged in battle together, facing the pandemic, and the family ties here are pretty strong. So if I left, I would feel that I was, leaving my family in the lurch. Of course I thought about quitting. Of course I thought, I can't take it another day. I just want to sob into my pillow, right? But you can't do that. You can't do that. And I really think it's It's love of county family. That's at the end of the day. And I am very stubborn, very stubborn. And I did, I don't want to let them get me down.
If you were given a do-over, is there anything that you would do differently, knowing what you know now?
I don't think I would do anything differently with a shelter in place. I think that decision ultimately ended up being very protective. I think that the real complexity came after the shelter in place, trying to figure out what to reopen, how to reopen, with what input from who, how to gather it, and how to put it together. That was really difficult, and I know that there's parts of that we could have done better. And I think it goes back to having like additional information and additional, like it felt like I felt like I had incomplete situational awareness to be able to make many of the decisions. So to like think back about what other information and what other awareness was necessary to make a better decision, and then what could we put in place to ensure that flowed.
There's been a lot of angry screeds from public health scholars who've noted that we've systematically defunded the public health infrastructure over the last 20 years, and now we're reaping what we have failed to sow, we might say.
Yes, we are.
And I'm sure you would add your voice to that chorus. What specifically should we be thinking about in terms of investments to make sure that we are better prepared next time?
Well, one is, I think that the boom and bust cycle really isn't serving anyone, right? So there's an emergency, we fund it, it's categorical funding, and then once that problem simmers down, we stop funding it. And we fund in categorical ways. We're going to fund HIV, we're going to fund STDs, we're going to fund TB, we're going to fund, we're going to fund COVID. And I remember like with Zika, we did all this work on Zika, and by the time the funding arrived, the Zika threat went away, was already gone. So it's really delayed. And so rather than funding, sort of the whack-a-mole problem as it comes, what we need to do is commit to, we need a public health infrastructure, some shared understanding that we need a public health infrastructure, that it's a public health good, that it matters, and that we fund it. And the two big pieces that are really missing are, one, data information systems. And this can't be something that's done by county. It all obviously has to connect at the state and federal level. And the other is the workforce is just tiny. There's no bench. So it's very, very, very fragile. And really every part. I can't think of any part of the public health infrastructure that I would call robust. None of it is. It's as I've said to many colleagues many times, it's like matchsticks and Scotch tape. We're trying to run a whole operation on matchsticks and Scotch tape. So we need some bricks and mortar.
There's some in the audience who'd like you to talk a little bit about the vaccination efforts. And one person asked in particular, what can a county do to convince vaccine skeptics? And let me just add to that, can a county convince vaccine skeptics? Or how should we be thinking about the last mile in our vaccination efforts?
This is really the focus of our work in the county right now, is how to reach people who are not yet vaccinated. So even though we have, actually, I think Santa Clara County has the highest vaccination rates of any large county in the entire United States. So we're doing extremely well. However, there are many groups, many communities that are still under-vaccinated, and pockets that are under-vaccinated, and the reasons are really varied. Some communities are under-vaccinated because there's a historic distrust of government and of a vaccine that was made so quickly. If it was made so quickly and promoted by the government, something's got to be wrong, right? Can't get over that. There's also enormous amounts of misinformation about the vaccines that have really taken off in social media, and it's very challenging to address those. And then finally, I would say, and this is one of our most under-vaccinated group is actually older white men. And some of the barriers to vaccination is this, it's a real sense of individualism that I don't know how the vaccine benefits me. I don't think that I am personally at risk, therefore I'm not going to get vaccinated. So, you know, a message about get vaccinated to help your community, that doesn't resonate with this particular under-vaccinated group. That message does resonate in other groups. In the Latino community, there are some people that will be moved to get vaccinated when they understand that getting vaccinated will protect their extended family. So it's a very, has to be quite tailored. And in many cases, I do not think that the government is the best messenger.
Maybe we could pull back and talk about California's response broadly, because I know this is not within your particular purview, but one person is interested in talking a little bit about prisons, which obviously has been a major hotspot in California. What are your own reflections on how the pandemic could have been managed better for that population?
I think once we had lab testing and the ability to screen people who were coming in, I think there was probably uneven, incomplete, imperfect application of that tool. So once you have an enclosed congregate setting, whether it's a prison or a homeless shelter or a long-term care facility, where you have a lot of people, many of them vulnerable altogether, you know, we've had across the state and in Santa Clara County, that's where we've seen outbreaks. And so we had the tools, sometimes difficult to implement them with testing. One challenge, we certainly saw this in our county jails, is just the sometimes the space wasn't available to be able to isolate or quarantine someone. So the person that tests positive, and there's all these other factors you need to consider when placing someone who's incarcerated. And frequently they found it really challenging to figure out how to do that. So my guess is that those were barriers that were faced in the state prison system, although I don't know.
How about other highly vulnerable populations? You know, there are many people, including some experts, who believe that a focused protection strategy that really targets public health interventions on the people most likely to die of COVID would have been a better way to go. Why didn't the county do more of that?
That is what we were trying to do from the very beginning. And the truth is, it's just simply not implementable. And so just to sort of like paint a little picture about how that's so challenging to implement, our long-term care facilities, where a lot of older residents, medically vulnerable, live, we had a number of outbreaks in long-term care facilities, and I can't remember, but a pretty high proportion of our deaths are from there. More often than not, the pattern would be that someone working at the long-term care facility would be asymptomatic. They would be the index case, bring COVID in, and then it would spread like wildfire. The people that work in the long-term care facilities, many nursing assistants and other staff, live in low-income communities, live in crowded housing with multi-generational family members. Many family members are also working low-wage jobs. And so you really can't separate the people that work caring for the vulnerable populations that you want to protect from the community. There's no way to separate them unless you have a completely separate, hermetically sealed workforce who doesn't wish to live with their family or in their community. And it's not implementable. It's a lovely idea, but it's not implementable.
I know we're coming up on the end of our time together. We have a lot of students in the audience today, and I wonder if you could speak to them a little bit. What advice do you have for students and trainees who are just getting started in the field of public health at what has got to be one of the all-time low points for the field in terms of morale? What can you say to inspire them as they enter this very difficult field?
Well, I think the opportunities are tremendous. So come on in. We'd love to have you in public health. Well, what is I think that a lot of the old guard in public health, we've been practicing public health for a long time and have a lot of experience. Many are leaving and exiting the field, and there's a lot of contributions that need to be made. Public health is a field where it's pretty, it's pretty small. It's pretty close knit. It's like I think of it as a big family. You're right. We all know each other, and you can make a big difference. You can do small things that make a big difference in public health, and it is enormously gratifying. I think if you want to do public service, doing public service through public health is a wonderful way to go. And I'm happy to speak with any students who would like to talk about that a bit more.
So I'm going to exercise the moderator's prerogative and ask the last question. Dr. Cody, I was just rereading an account of Captain Chesley Sullenberger's Miracle on the Hudson flight, where he landed a plane in the Hudson River after birds flew to the engine. And one of the things he said was this: one way of looking at this might be that for 42 years, I've been making small, regular deposits in the bank of experience, education, and training. And on January 15th, the balance was sufficient so that I could make a very large withdrawal. What deposits have you made in the bank that were important to your success in managing this pandemic? And what aspects of the crisis did none of your deposits prepare you for?
Well, I have to say that a lot of this felt like trying to pilot a plane with an engine down. So I think the analogy is apt. More than anything, I actually was grateful that I'm not a 20-something trying to manage this. I just think that general life experience of knowing that you've gotten through something hard and you came out the other side, and you know what, it all works out. You're gonna manage. That was actually quite helpful. I think that part of the practice of public health, it is looking at a lot of data and evidence and models. But there is an art to it. A lot of it is judgment. I mean, just like in clinical medicine, a lot of it is good clinical judgment. And I think that there's public health judgment that you gain as you go along. Just one final thing that I didn't mention, but I think is really important, and that is when the pandemic hit in Santa Clara County, we had so many county retirees from public health and other departments that just showed up and said, I want to help, what can I do? And that is part of how we expanded our workforce. And one of those people was my mentor, the former health officer, Marty Fensterscheib, who really became one of my key thought partners. So I could always rely on Marty when I was trying to make a decision. And so we both had his 40 years of public health experience and my 20 plus years of public health experience to put together to try to render the best public health judgment that we could for the decisions to be made.
Thank you so much for entertaining all of our varied questions. I'm going to turn things back over to Rob to wrap up.
Wonderful. Thanks so much, Michelle and Dr. Cody. It has been extraordinarily illuminating to hear your reflections on this extraordinary past 18 months and the challenges of leadership that you faced along with so many of your other public health colleagues. I hope this is just the beginning of what will be a longer conversation. Your invitation to be in touch with students who might be interested in a public health career is very generous, and I hope that some will take you up on that invitation. It's been an extraordinarily vibrant event, even though we're at the tail end, I hope, of Zoom life. May this be the final event that the Center for Ethics and Society holds on Zoom of this past academic year. Plans at Stanford are to return to ordinary business starting in September, when the Center for Ethics and Society will resume its programming. We've had nearly 300 questions posed here on Zoom's Q&A, And that's just a small inkling or a sign of the extraordinary interest in the topic today. Dr. Cody, I thank you for your time, your leadership, and your reflections today. I thank the audience for joining in. I want to thank the entire team from the Center for Ethics in Society for the infrastructure of this event. And I want to thank Professor Michelle Mello for her own extraordinary leadership and the questions she had in the event today as well. Thank you all for joining, and I hope to see you in person sometime later this year. Bye.